This conference will now be recorded.
Well, good morning, everybody. Since it's 10 o'clock, we'll get started. So for those that don't know me or don't know who I am, my name is Matthew Cole. I work with our clients to come up with creative cost containment strategies. Just a couple housekeeping items. Your line should be muted, but if not, please go ahead and do so. If you have any questions, feel free to put them in the chat box below. We'll address all of them at the end of the webinar. The webinar is being recorded, so we can send out a recording of the webinar if you missed anything or want to pass it along. So I guess I'll open up with a few minutes of conversation before I turn it over to our presenters. Clearly, it's safe to say that every business has gone through some significant changes over the past 6 weeks, all of which were really unforeseen. Unfortunately, I think we still have a lot of uncertainty ahead of us, especially here in Michigan as we try to reopen our economy. As I put myself in your shoes, I think about you're probably spending most of your time figuring out how we keep our doors open, customers satisfied, and maybe most importantly, our employees safe as they return to work or stay at work. I'm sure cost savings measures have to be on the top of mind for all facets of your business. So I guess I'll ask you a question. Where does healthcare factor in? Think about if healthcare was potentially reduced by 20 to 30%, how could that help with any business changes or transitions that you may be thinking about? This is really why we're here today and why we're Michigan Planners looking to launch a series of 5 webinars over the next 5 weeks. We want to arm you with some various strategies, and we'll start here today with Sedera and Health Access Solutions. So I'm excited to introduce Bill Thomas from Sedera. He'll talk about their member-focused medical cost sharing program. Bill is the head of sales and has overseen Sedera's exponential growth since 2019. Sedera has been named one of the fastest growing companies in Central Texas. So Bill will spend about 25 minutes talking about the Sedera solution and then turn it over to Joel. Joel will talk about recent legislative changes for individual health reimbursement accounts or HRAs for large employers, coupled with Sedera that really makes a win-win solution for your business and for your employees. Joel's the co-founder of Health Access Solutions and has spent over 20 years in the industry, previously as an agency owner himself. So once we're all finished up with Bill and Joel, Joel will turn it back over to me. I'll close this out. But without further ado, Bill, go ahead and take it away.
Thank you, Matt. I'm going to go ahead and share my screen here. Is everyone able to see my screen?
We are. Thank you.
Awesome. So good morning, everyone. Bill Thomas. I am speaking to you from Austin, Texas, where the weather is absolutely beautiful. So at least while we're all quarantined, I'm able to get outside occasionally. Pleasure to meet you all remotely. I'm going to give you a high-level overview of what Sedera and medical cost sharing is. First and foremost, I want to be clear that it is not health insurance, okay? But it is an alternative way to pay for your healthcare needs. Medical cost sharing has been around for a very long time, over 31 years. And so Sedera did not recreate the wheel, but what we did that's significant is the healthcare sharing ministries that have been around and doing it successfully for 30 years have a faith element and a faith component when you join them. Sedera has removed that faith component and allowed employers like yourself to offer this to his and her employees. Traditionally, people come to us because they're looking for a lot of reasons. We all know the healthcare system's broken at this time. Health insurance keeps going up and up. And so what you'll find is we have transparent pricing on our website. Whether you're a group of 3 or 3,000, the pricing for everyone that joins the Sedera community is the same. So at sedera.com, you click on Employer Solutions, you'll find that the pricing's on there. And again, whether you're in Austin, Texas, or Michigan, the pricing across the board would be the same for the entire community. So what is medical cost sharing, and why is it not health insurance, and why is it different? So when you join a community like Sedera, and right now there's 27,500 members, or maybe it's 28,500 members. We're right around the 28,000 mark. And every member of the community that joins pays a monthly membership, just like you would an HOA or a gym membership. you would pay a monthly membership to join the Sedera community. And Sedera Inc., where I work, we are the facilitators to pay out the medical bills as they come in, based on the guidelines that we have established. So when you join Sedera, every member is a cash pay patient. There is no in and out of networks. Our members have the freedom of choice on where they want to go, which is a breath of fresh air when you're deciding on where you want to get your health care. We also believe in people over numbers. And what I mean by that is one of the biggest accolades we get and the best compliments we get is that we actually pick up the phone and we talk to our members. We have our member services team based here in Austin, Texas, not a third party, but actual employees that sit next to the sales team that answer questions, because when you join a medical cost sharing community, it is a little bit different, and we want our members to feel like they have a valued coach on their side helping them walk through that. One of the cool things is when you join something like medical cost sharing, it's a difference in paradigm shift. And what I mean by that is you will not have an insurance card. You're going to be walking in as a cash pay patient guided by the medical cost sharing community. And so we teach our members to be savvy shoppers of their healthcare. If you really think about it, it's the only industry in America where we aren't savvy consumers. Imagine going into Best Buy and buying a TV, not knowing what the sticker price is, walking to the counter, being told it's $10,000. Well, you like that TV so much that you buy that $10,000 TV, you take it home, and a month later, you get another bill for another $5,000. That's what's happening in the healthcare industry. With Sedera, we teach you how to get upfront pricing at a cash pay discount, and we're there to guide you along the way. Our members do make a commitment to healthy lifestyle. It's not a secret that if we're all doing our part on exercise, diet, and watching what we eat, that we will probably be healthier and we will probably go to the doctor less. And so what that does is it saves that community and all of us on keeping our membership levels at the lowest rate possible. And then lastly, we do everything on a sharing on a per need basis. And so what I mean by that is, the best example I can give is this. In the car insurance, everyone has car insurance, or at least you're supposed to. And when you take your car in for an oil change, gas, tire rotations, or any minor event, you are responsible for paying those bills, right? But when you take your car down the road and you get in an accident, you're responsible to pay that one-time $500, $1,000, whatever your deductible is, and then the insurance company kicks in. And that's exactly how Sedera works. When you join the community as an employer and your employees, there are three options that I will talk about. There's a $500 option, a $1,000 option, and a $1,500 option. So when you join, you pick one of those, and when your medical bills exceed that IUA, what we call initial unshareable amount, that's when Sedera kicks in. And I'm going to walk through a couple examples so it makes crystal clear sense of what I'm talking about here in a moment. So we have three components that we dissect when we talk about medical cost sharing. Medical cost sharing, where we really shine, is the large costs. So things like cancer, heart attack, major surgeries, things of that nature. That's where medical cost sharing helps you for that large catastrophic stuff. Now, the small to medium costs, Sedera also can help. We have telemedicine built into our product. It's access, for those that don't know, it's access to board certified doctors 24 hours a day, 7 days a week at no additional charge. I've used it several times for my daughters, where I make an appointment online. 8 minutes later, a board certified doctor is calling me back, diagnosing my daughters, and then even prescribing medication, and taking it as far as emailing me a doctor's note for my daughter to take to her school. So it's a really cool service that we offer to all of our members. Joel, who is gonna be speaking here in a moment, will also talk about some ancillary products that he has built in that will take care of that small to medium cost as well. And then lastly, on the preventive care side, we do include three of the largest preventive items into our membership at no additional cost. So a preventive mammogram over the age of 40, a preventive colonoscopy over the age of 50, and childhood immunizations from age 0 to 18, those are fully shareable, meaning you pay for those and those are 100% reimbursable. So let's talk about what a need is. Okay, this is the most important slide on our deck and the most important concept to understand when you're working with medical cost sharing. So a need is defined as one or more expenses related or caused by an illness. You have what is called your initial unshareable amount, and that's what members pay before sharing begins. And so, as I mentioned earlier, you have three options when you join Sedera: 500,000, 1,500. So if I were to join Sedera at the middle option of $1,000 IUA, and I hurt my leg and I went to the hospital and I had an MRI done and they performed surgery where they inserted a rod into my leg. They sent me home with pain medication, antibiotics, and for the next 3 weeks I have rehab. All of those procedures and all of those bills would be considered one need. I would be responsible for the first $1,000. The rest of my medical bills would be sent over to Sedera for sharing. And the way that looks is we have a mobile-based app, and I'll show you a couple still frames on that here in a moment, where you actually take a picture of your itemized bills, upload them, send them over to our needs coordinating team, and we process those bills. Here's the difference on how it works with insurance. We actually send the money to you, the member, and then you, the member, pay the provider. The reason we do that is we want our members to have total access to their provider. We don't get in between the patient-doctor relationship like the insurance companies do. We leave that up to our members to do. So we do pay the member directly, and then the member pays the provider. We do, when those bills come in, here's how we save the community an exorbitant amount of money. So let's say my surgery costs $10,000. Any bill that goes over $1,500, we send it down to our sister company, the Caris Group. Now, the Caris Group does bill negotiation on behalf of all the members of Sedera, and they do it for some of the largest insurance companies in our country. What they do is they have 25 years of data. They also use Medicare as a baseline on how much a procedure should cost. And so they'll look at my bill for that surgery for $10,000 and say, yeah, that is a fair market price for that surgery. We're going to go ahead and cut that check to Bill, and he's going to receive it within 7 to 14 days. If the Caris Group finds that that bill is an exorbitant amount for that procedure, they will then go into bill negotiation on behalf of the community and me, the member. They will talk to the provider directly. Once they get a agreed upon a price, they will then cut the check to me, the member, within 30 to 90 days. It all depends on how quickly the provider responds and how quickly I'm submitting my bills, but average it's 30 to 90 days. All the while the provider's kept in the loop, and you, me, the member, is kept in the loop on where it stands in the process. By doing this, we, on average, we're saving the community about 52% off medical bills. And so when that check is cut to me for that procedure, and let's say it goes from $10,000 down to $5,000, I know that I will not be in jeopardy of being balance billed by the hospital because it is an agreed upon a price. The last thing I'll mention here on this page is we limit your out-of-pocket exposure on that big stuff. So I had chosen that $1,000 IUA. I went ahead and had that surgery done. I paid $1,000. Let's say within my membership year, I had 2 more catastrophic events where I paid out $1,000 3 times. The Sedera community at that point would jump in for my 4th need. So my 4th need, I would have $0 out of pocket. It would be fully shareable. Same thing goes for a family. We limit it to 5. And the reason we do that is it's kind of like a deductible. We limit your out-of-pocket exposure on that big stuff. Okay. Here's a real-life example of how medical cost sharing works. This particular example is my CEO. His son, Brooks, had chronic ear infections. Prior to joining Sedera, him and his family were on a $5,000 deductible health plan. They took Brooks in for several doctor's appointments, a specialist, and they finally inserted tubes into his ears. On the left-hand side, in purple, you can see what it looked like when he was on insurance and the family was on insurance. They had 4 doctor visits and a special visits where they had co-pays, they paid per prescriptions and the in-office injections. They also paid for the surgery for $2,100. Why did they pay out $2,525? Well, they had not met their deductible of $5,000 yet. So they paid out cash $2,525. Had Jamie and his son been on medical cost sharing at the $500 IUA level, that surgery would have only cost him and his family $500. Now, this surgery happened in the fall. The following spring, Brooks's ear tubes fell out. They had to take him back in for a second surgery. So they had that $2,100, they had to pay it again because they had still not met their $5,000 deductible. So they were out $4,600 for 2 surgeries. Had he been on Sedera, here's a big difference, so pay attention. On the second surgery, if you do not go 12 months symptom-free, so let's use my leg, for example. If I have something go wrong with my leg after rehab within a 12-month period of time and I have to have a second surgery, it would be $0 out of pocket. Same thing goes for this medical procedure on his ears. Because he did not go 12 months symptom-free, this second surgery would have been $0 out of pocket for Jamie and his son. So it's pretty simple to join Sedera. We just ask our members to choose a healthy lifestyle, strive to be healthy. We do ask some very strong personal commitments around not using illegal narcotics and not operating a vehicle while intoxicated. So you actually will initial on your application that I, Bill Thomas, will not operate a vehicle while intoxicated. So if I join the community and I actually get in an accident from drinking, my medical bills will not be shared with the community. We will not ask our 28,000 members to share in that expense. So it is a strong personal commitment and people have to understand that. We do allow for tobacco use. However, we all know it's bad for us. So we do charge a $75 surcharge. I want you to please take note of that footer at the bottom, especially if you have an employee that's over the age of 50. Tobacco use, if you're a tobacco user in the Sedera community over the age of 50, we will only share up to $25,000 on the top 4 disease states. And that is with tobacco use, and that's heart disease, COPD, stroke, and cancer. Tobacco use in our community, that includes cigarette smoking, chewing tobacco, and vaping, okay? Like the celebratory cigar does not fall in that category. So if someone age 50 or above asked me if Sedera would be a good fit, I would probably tell them it's not. But that's when Joel talks here in a moment, he'll talk about some alternatives on when Sedera might not work for someone. Medications, here's how we handle medications. We put them into 2 buckets. We put them in a curative bucket and a maintenance bucket. So curative medications would be, going back to my surgery, the pain medication and the antibiotics that were sent home with me after my surgery. Those are part of the cure, they're part of my need. I would submit those bills just like I would my surgery cost, and I would be paid for those. Maintenance medications are handled differently. If you come into the Sedera community and you have a maintenance medication like high blood pressure medication, that is our members' responsibility to pay for. So we offer free programs like GoodRx to get medications at a heavily discounted price, and there's no charge for that app. We also have a buy-up program through Liberty Benefits, which is $27.50 per month, that offers drugs for 90-day supplies from countries around the world. This is a very common practice where medications found at a significantly discounted price. So maintenance medications, if you're part of the Sedera community and you're diagnosed with something and you have a maintenance medication, we will share it for the first 120 days. After that, it's our members' responsibility. Pre-existing. So when people ask us, how are we able to keep our monthly rates so low? It's a combination of a couple things. One, our members are cash pay patients, and first and foremost, they usually get a significant discount because of that. The second part is how we handle maintenance medication on what I just described. The third is the CARES group, which does bill negotiation on behalf of all of our members. And then lastly, it's this right here, pre-existing conditions. So all of your employees will be able to join Sedera. We don't turn anyone away. However, our guidelines are structured in a manner where it might not make sense for someone. And so what I mean by that is when you join Sedera, we ask all members or all applicants to list any illness, symptom, or treatment they've had in the last 3 years. Anything they list would be considered a pre-existing condition. Therefore, in year 1, we won't share anything around that condition. We'll share everything else, but anything they've listed that they've had in the past 3 years would not be shareable. Year 2, it tiers up to $25,000, year 3, $50,000, and then finally, it's a fully shareable need after year 3. And so, I came into the community with a couple minor pre-existing conditions, didn't faze me, but someone that might have something extreme going on right now, they're going to want to consider how much risk they want to take on, knowing in year 1 nothing would be shareable around that condition. Here's some ancillary services we provide. I've already talked about telemedicine, but I will touch on the second MD here, that second bullet point. This is a service we offer that's absolutely fantastic. It is access to the best board certified doctors in their specialty in the country. So they utilize hospitals like Johns Hopkins, Mayo Clinic, MD Anderson, you name it, the best specialists in the country. So if you're someone that has chronic back issues and your specialist or your doctor wants you to get surgery, you have the ability to call up 2nd.MD. They will gather your information from your specialist, look at your symptoms, your diagnosis, and agree or disagree with the recommendation of getting a surgery done. We do this for 2 reasons. 1, we want you to get the best treatment possible. Number 2, doctors are about 17 years behind in their education. So to get that second opinion might be really important, and it should be important. And then third, statistically, and I've seen 2 different stats ranging from 20% up to 30% of all surgeries in the United States are not necessary. So if we can avoid surgery, it's not only saves you the trouble of going through surgery, it saves you money and it saves the community money. And so for using this service, we credit you back $250 of your IUA. Now, you don't have to take 2nd.MD's opinion or recommendation. You could go with your specialist and continue with that back surgery. We just want you to have the best option of healthcare choice when you make that decision. Lastly, I've already touched on our member advisors. They're there to coach you, whether it's finding medical care and cash pay friendly providers or getting you connected with 2nd.MD or telemedicine. They're there to support you. So in summary, Sedera is there again for that large stuff. If you have cancer or a heart attack, your bills are shareable until you're cured. There's no cap. Small to medium cost, remember where we have that telemedicine services where we help you. If you go in for something that falls under your IUA, just like the gas or oil change or tire rotations, you're responsible for that. And then lastly, the preventive care, which I talked on, where we share in the colonoscopy, mammogram, and childhood immunizations. With that, I'm going to turn it over to Joel at this time, who's going to talk about the ICHRA option. Sounds like some legislation stuff that's going out there, as well as some things that fall outside of the scope of Sedera. So, Joel, I think, I don't know, Matt, if you have to turn it over, if I have to turn it over to him.
I will do that right now. Thanks, Bill. Great job. Here you go, Joel. You should have presentation skills or ownership now. One thing to mention as Bill signed off. So if I'm putting my HR hat on for a second, I look at Sedera and it probably fits a good part of my population. A lot of non-users of healthcare or low users of healthcare. And when you see some of the premiums that are attached to the medical cost sharing, you'll see the significant benefit. But you're probably also thinking, I have some high risk employees. So really, Joel, I won't steal his thunder, but Joel and his team has come up with a solution that identifies an opportunity for those that may not be a good fit for Sedera, coupled with some changes in how HRAs are handled at the individual level to make sure that they have adequate coverage. And the sum of the parts still is significantly lower than traditional insurance. So Joel, if you have a presentation and we can hear you, I'll let you take it away.
Great, thank you. Well, Bill led off by saying that he was coming to you from sunny Austin, Texas. I'm coming to you from rainy, gray, and dreary Augusta, Maine. So we've got some different weather out our windows today. But thanks for joining. So my name's Joel Allenbaugh, and I'm the Chief Development Officer with Health Access Solutions. And as Matt indicated in the introduction, my experience is 20 years in the insurance business, and really there's this great opportunity both with organizations like Sedera and the sharing community, which is a growing, rapidly growing method for managing healthcare expenses, but also new regulations out of DC in the last year that I think create a great opportunity for employers to really look at alternative structures from traditional health insurance. And so what I'm going to do is walk through a little bit of the problems. I won't spend a lot of time on that because I think we all know what those are with traditional healthcare and health insurance. What an ICRA is, which is an individual coverage health reimbursement arrangement, how it works, and really more how it works as a comprehensive solution coupled with Sedera. And a product that we developed through Health Access Solutions, which is a health access employee assistance program I'll touch briefly on, and then just give you a little bit of an idea of how this works for real employers. So I think we all know the dynamics that we're facing with traditional health insurance, and the challenge is that the costs just never seem to come down. And despite all the activity that we see, whether it's at state by state regulators and legislatures or in Washington, D.C., the thing we all seem to be failing at is really getting control of cost. And the challenge, of course, with that is not just managing that as an employer, but the fact that oftentimes as costs go up, so do deductibles, so do out-of-pocket exposure, co-pays, things like that. And so from the perspective of your employees, oftentimes as their costs go up, the value of what they're getting out of the health insurance programs is actually going down. And when you take a look at an average person in this country, that's what typical healthcare utilization looks like. It's not high healthcare expenses every year. It's actually relatively low healthcare expenses in most years, and then every once in a while a spike. And we all know that not everyone fits that average, that there are certainly examples of people who have a particular condition and a consistently high cost need, but for the vast majority of us, healthcare utilization looks something like this. This is sort of a typical employee share toward the cost of a group health insurance program. And, and deductibles, I think, as we all know, are pretty high. And so when you have employees sort of voicing that they feel as though they're paying a whole lot and not necessarily getting a lot of value out of a health insurance program, oftentimes that's a true statement, for the majority of people. And we certainly, we know that not a lot of people are using a lot of healthcare services. It's actually about 1 in 10 that have a more urgent need in a year. It's about 1 in 20 of us that are hospitalized. And I certainly don't want to downplay the importance of having protection when those expenses hit. That's when it gets real expensive. But it's not the annual reality for most of us. What is the need to have access to primary care. 2 out of 3 of us do need to see or speak to a doctor in a year, and 2 out of 3 of us do need to fill a prescription in a year. When you think about, sort of designing health insurance or healthcare, and if you could really start with a clean slate, sort of what would it look like? I think looking at this through 2 lenses. First, from the employer's perspective. I've worked with a lot of employers over a lot of years now. I've yet to find one that's told me that they're particularly interested in and excited about being in the insurance business. But I do think that employers generally have an interest in the health of their workers. And I think, you certainly want your employees to be healthy. You want them to get access to care when they need it, not just for their own sake, but to be able to come to work and to be productive. But The trick is being able to do that, meet that ideal, and do it in a way that's both affordable and predictable so that you can maintain that investment in the health of your employees over time. And from the perspective of the employees, it's really about trying to bring back to the center of the equation that doctor-patient relationship. The number one complaint in this country about healthcare is that it's almost impossible to predict the cost of a service before you go use it. And the number one reaction to that challenge is that people avoid and delay care. And that's a huge problem, both in the short term and in the long term. And so really having a solution that makes sure that your employees have access to care when they need it is really critical. And obviously doing it in a way that's affordable so they can afford to both participate and to cover their families is also important. So I want to just, with that baseline, talk a little bit about what this new regulation enables. And you may be familiar with a health reimbursement arrangement. They're relatively common, and you may have used one or be using one in your benefit design today. And health reimbursement arrangement is really just a tax vehicle. It's a way for money to flow from an employer to an employee without a tax consequence. And typically, we've seen HRAs utilized to help offset the out-of-pocket expenses. So oftentimes, an employer may be using an HRA to cover a portion of a deductible or some of the out-of-pocket costs that their employees may face. The new regulations that took effect January 1st of 2020 expand the concept of a health reimbursement arrangement to allow you to also contribute dollars as an employer on a tax advantage basis to pay for individual health insurance coverage premiums. This was allowed years ago and then wasn't allowed, and then new regulations are sort of enabling it with a number of enhancements. The concept of that is that you're providing dollars so that employees can buy individual coverage. I do want to point out there's structure behind that. It's typically administered by a third-party administrator. There's support to make sure employees know how to go elect those individual plans, and then the money flows again on a tax-free basis. I also want to point out that the ICHRA is not necessarily a solution in and of itself. When we've done analysis, if you take a traditional group health plan and you simply say, rather than paying for a traditional group plan, I'm going to give my employees dollars and let them go buy individual coverage, rarely is that less expensive. Individual coverage is expensive, nor does it necessarily improve the access to care, as individual plans have a lot of the same challenges that we often see with group plans. But what's a very interesting opportunity is to utilize the ICHRA in combination with other solutions like Sedera to create a very comprehensive option for your employees that's more affordable and make sure that you're also not leaving anyone behind. So I also want to point out, for those that may be larger employers, and specifically employers that are applicable large employers under the Affordable Care Act, where you have an obligation to offer coverage or face a penalty, the offering of the ICHRA satisfies the ACA employer mandate, and that's a really, really critical piece. And it satisfies both Part A and Part B, and I won't go into detail about all the component parts of how the employer mandate works, but it checks all the appropriate boxes that you need to check to make sure that you're not, moving in a direction that's going to create a separate cost by having to pay penalties to the federal government. It's also, the ICHRA cannot be coupled with the traditional group health plan. So you can't sort of have it's an either or game, if you will. You can't have a traditional health plan and then have an ICHRA and then say, hey, employees, take the path that works well for you. But what you can do is you can couple an ICHRA with a non-health insurance solution, and that's really the value of coupling with a company like Sedera, and the reason why the plan that we developed through Health Access Solution is an EAP, which is also very purposely not an insurance policy, and I'll talk a little bit more about how that works in a moment. I also want to point out that one of the things that we do at Health Access Solution is partner with innovative brokers and agencies like Michigan Planners, and help to bring some pretty sophisticated analysis tools that can really help you as an employer do the analysis to determine, if I go with a solution like this, if I am a large employer, how do I make sure that I'm mitigating mandate risk and penalty risk? And the slide that you're seeing, I won't go into detail, but we're sort of using this tool to look at your employees, look at where they are as it relates to their income and their age, and then really help to develop and dial in ICHRA contribution levels that adequately protect you from ACA mandate penalties, specifically trying to make sure that we're addressing the ACA affordability standards. And I want to point out that, the challenge, I think, with replacing traditional group health plans in the past is that, you have this sort of expectation of what the plans cover with a traditional plan. When you use Sedera even alone, there are some components that, as Bill described, that are not picked up under Sedera, treating more like an auto insurance, sort of a dynamic, than a health insurance, which is part of what helps make it more cost effective and affordable. The Sedera alone doesn't sort of check that box on the employer mandate, so you do have that to consider. But what we've really tried to do is to make sure that we are coupling with the solution this employee assistance program that helps to really check all the boxes, if you will, and make sure that you have a very complete solution that will work both for you as an employer and for your employees. The solution looks something like this, and I'm going to move relatively quickly through this, but the blue that you see on the screen, and this is really sort of through the lens of your employees, is this employee assistance program that we utilize as sort of a foundation. And what that does is it provides, in combination with the 24/7 telemedicine that Bill described through Sedera, a virtual dedicated physician as well. And that's really just to make sure that employees always have access to a physician for them and their families when they need it, and that they can access it without a cost barrier. So there are no copays or costs to sort of take advantage and utilize that physician access. And we also do provide some discount prescription programs to make sure that people can get the medications that they need at a reasonable price, and then really try to complement the Sedera program for preventive services. So you heard that Sedera covers a preventive mammography, preventive colonoscopy, childhood immunizations. Through the EAP, we in addition reimburse an annual physical with a local physician, flu shots, the lab work that is often coupled with an annual exam, and a number of additional services like preventive eye exam that to just round out that preventive coverage, to make sure that employees are taking care of things early and not letting things become bigger problems later. And then what this allows you to do once that foundation is in place for your employees is give them a choice of choosing an affordable option like Sedera, and for those employees that maybe that isn't the best fit for, giving them the ability through the ICHRA to purchase a more traditional individual plan. So it really makes sure that there's a good solution that works for your entire workforce. And the solution ends up looking like this. This is sort of through the lens of the employer, where you have this foundation that covers all of your benefit eligible employees. And then when you give choices, we see a split that looks very, very close to this the vast majority of the time, where Sedera works really well for the vast majority of your workers. It's a much more cost-effective solution, yet you do still have some portion of your employees that may have a need for a more traditional plan, whether it's because of a specific pre-existing condition or a specific expensive maintenance medication, and just making sure that those folks, again, are not left behind. I'm gonna jump out of this presentation for just a minute and give you a quick look at something. One of the things that we've developed at Health Access Solutions is an analysis tool to help you as an employer, evaluate a solution like this, very specific to you, your workforce, and your cost, and really understand what the implications of a change to this type of a solution might look like for you. And this is an analysis that we work with folks like Michigan planners to really help dial in for those that may be considering this. And what you're looking at is a tool where we start by bringing in information from your company, so your employees. You'll see a list of the census below, your current plans and costs. We can then look at the individual plans that are available to your employees in your state and in your county. We can look at how those rates change based on age. You may be aware that individual policies are age-based. And you'll often see something that looks like this, where rates for individual policies increase relatively modestly until you hit about your mid 40s or so, and then they really start to kind of hockey stick up as you get older from there. That's really important to know so that you can design your ICHRA contributions so that they're equitable, for your workers, wherever they happen to be on that age scale. And then we can really, sort of dial in for you, here's the employees broken out by age and by level of coverage. We can sort of look at the employees that you may have eligible for your plan that don't participate. We can take a look at the individual plans available, find one, comparable to your group plan, set ICHRA contributions, and really look at, how would it affect your employees if they bought an individual plan, based on some ICHRA contributions that you designed for them. What is their net cost to buy that plan? What you're seeing green is, equal or less than what they're paying today. Red is more. And you can really sort of move those dials to make sure, A, you understand how a move like this could impact your employees, and also have the ability to really dial in that solution so that it's going to work effectively for you. And we do also then have the ability to pull in Sedera, pick the IUA that you may be offering. If you're offering a single IUA, set contributions, and then really from that be able to look at how would the math look for you as an employer in various scenarios. We can also look at the affordability for your ACA mandate obligations, and just really make sure that you understand exactly how a solution like this will work both for you and for your employees. And I'll jump back into the presentation here. And just a few more slides. I just want to give you an example. This is an employer that we did the analysis for recently. And one thing, we're looking for ways of providing higher value and lower cost, but not just for employers, also for employees. And oftentimes what we see is an opportunity for employees, to provide access to care for their families at a much lower cost. And in this particular case, it was almost a $15,000 annual savings for employees covering their families, a significant savings of about $250,000 for the employer as well, and really an expansion of coverage by now having this foundational health access EAP covering all employees, and really being able to do all of that while managing or reducing employer mandate risk, setting predictable costs going forward, and really trying to provide better health and better value to employees. Our objective is not to provide insurance. Our objective is to provide access to care that's valuable for our workers. In this particular scenario, we can also look at, for this particular employer, the red represents what their costs were currently. They were facing a renewal, so we're representing that as well. And when you see these other columns here, the yellow was looking at what the cost would look like if all of their employees chose individual plans through the ICHRA. And I want to point out that you don't see cost savings here, and that's really typical. We also look at what if everybody chooses Sedera. Neither of those outcomes is likely. It's going to land somewhere in between, but we can also look at what the most likely scenarios are and really determine, kind of see what where the stakes are in the ground, if you will, and then estimate what cost is likely to be under one of these scenarios. And then we can go a little deeper and sort of look at that at the employee level. You'll see in this case, the employer is paying a fixed high cost currently. The yellow represents the ICHRA contributions, which vary by age, and the green represents, in this case, a contribution level for Sedera, and that's where it creates some real savings for the employer and for the employee as well. So this looks at employee cost at the individual level, and this looks at employee cost at the family level. And and oftentimes we see a dynamic like this where employees have the opportunity to cover families at a cost similar to what they're spending today to cover just themselves. And just I'll close with this. I want to just offer an example. We've seen these models work really well for a lot of employers. So this particular case study looks at a pretty complicated employer. They have about 500 employees. They actually own and operate convenience stores in 3 states. So they have a particularly dynamic workforce. They have a lot of lower wage workers on the front lines in their convenience stores. They're in every sort of rural nook and cranny in the 3 states that they're in. They're in New England. So it's just a challenging sort of workforce to manage for healthcare expenses. And they've been dealing with really high expenses for quite some time. And by moving to this model, not only were they able to avoid a significant premium increase, they were able to really reduce their ACA mandate exposure. They were able to provide pretty valuable access to care for a much larger portion of their employee group. They in the past had less than 30% of their benefit eligible employees actually participating in their plan. The vast majority of their workers were going without. And for those employees that were participating in their plan, that were able to move over to Sedera as a result of this solution, employee costs dropped dramatically. So for employees with single coverage, they put almost $4,000 back in their pockets and about $10,000 back in the pockets for those covering their families. All of this while spending less as an employer as well. So the math is not always quite that dramatic for every employer when you sort of look at this model, but it's encouraging to see that there are alternatives out there for employers to consider where they could lower costs. They could lower costs not just for them but for their employees, and I think really have an opportunity to step back a little bit, think about what are we really trying to do to provide quality access to care to our employees, and can we do that in a way that's affordable and manageable over time. And I'll just leave that screen there for just a moment. Just has some contact information. But Matt, I guess I will turn it back over to you.
Perfect. Thanks, Joel. We have a few questions we'll go through. So let me see what we have here. Deb, thanks for the note. Family is good. Hope yours is good. Bill, can you talk a little bit about Sedera rate stability? How have premiums or pricing, how has that changed year over year?
Yeah, sorry. I had to unmute myself there. So I meant to, if I can pull my slide deck back up, actually, you could just check it out at sedera.com. But so we've been in business for 5.5 years, and we've had 2 price changes. We actually had 1 decrease and 1 increase. The way Sedera works is, it is not health insurance. And so these questions usually come from health insurance brokers more than they do employer groups. But when you join a medical cost sharing organization like this, there is some risk when you join. And what I mean by that is there's no reinsurance on the back end. And so I use this example right now. We're in this strange time with the virus. I have brokers that have been selling us for a number of years asking how we're doing, and I say just fine. But if, let's say, out of those 28,000 members of the community, and we had a significant amount of virus episodes where we're getting 10, 20, 30, $40,000 worth of bills for each member, what would happen to that bucket of money? And the answer is this: if we ever have 3 consecutive months where the needs of the members coming in are greater than the monthly contributions coming in, our board reset the rates for the entire community. So all 28,000 of us, our rates would go up at the same time to offset the run on the money. So if you think about it, the best way to describe it is an HOA or maybe a country club membership. If you're a member of an HOA and they have to put a new roof on the community center, or they have to put in a new floor for the pool, they would raise the rates to the HOA, and then they would lower them back down after those significant things are taken care of. Now, let me be clear, we've never had to do that, okay? But that is an option for us, and that's how we handle if we ever have a situation like that.
Perfect. Thanks, Bill. Joel, maybe you want to take this one. Can I switch plans mid-year, move from the ICHRA to Sedera or Sedera ICHRA as an employee?
You can, and I think a couple things, a couple points on that. So one is you can switch anytime. You'll obviously want to, understand any implications with terminating, if you have a group health plan. Usually there's no issue in doing that mid-year, but you'd want to just, I don't want to make any assumptions on any obligations you might have on that end. You would also want to be attentive to deductibles and out-of-pocket potentially for employees. Typically, when you transition from a traditional plan, for those of your employees that may need to go through the ICHRA for individual plans, they typically will not credit deductibles incurred under the group plan. So sometimes that timing may have an impact on an individual employee that you want to at least be sensitive to. And the other last point I'll make on this is that when you offer an ICHRA, that is a qualifier for enrolling in an individual plan outside of the typical annual individual market open enrollment. So by adding the ICHRA, that does create a window so that the employees that may need a more traditional plan will have the ability to enroll in that plan, even if you happen to be in the middle of the calendar year.
So for example, maybe I have an employee who takes Sedera, and they are faced with a health condition that, that requires an expensive medication that otherwise would only be covered under a discount program or Liberty benefits, which, Bill, if I understand, it's international mail order. Is there an opportunity for that employee to switch over to an ICHRA?
There is, although I would, the one caution or caveat to that is that how you structure, that may create some dynamics that you need to consider. So for example, are you setting up a Section 125 plan? Are your employee contributions towards Sedera membership being deducted on a pre-tax basis? So that, creates sort of the normal Section 125 rules around, changing without qualifying events. And then the individual market has an annual open enrollment period. Being newly eligible for an ICHRA creates a qualifying opportunity to enroll in coverage. It doesn't necessarily create a qualifying opportunity to, sort of change my mind on that coverage throughout the middle of the year. So you will just want to be attentive to a couple of those dynamics. But generally speaking, you do have quite a bit more flexibility with these types of programs, including, perhaps it's a family member. Most families, it's a single family member, single health event that hits a deductible in a year. you may have a family member that is better suited for a traditional plan, but Sedera may be a great fit for the remainder of the family. With these types of solutions, you can also sort of get down to the family level member and find the solution that works the best for them.
Perfect. Looks like one more question here. Is the EAP offered to all employees, even if they don't take Sedera or the ICRA?
It is. The EAP actually has to cover all benefit eligible employees. That's a regulatory issue. The EAP, in order to qualify as an EAP and not be considered any type of insurance plan, which would disqualify the ICRA, one of the boxes you have to check to meet that definition under the regulations is that it has to cover all benefit eligible employees and has to be funded by the employer. You can have your employees pick up the cost, add dependents, but you have to cover the cost of the EAP for all benefit eligible employees.
Perfect. And I think where my mind goes with an EAP program is different, very different from your EAP solution. This is not a 3-call if I have financial, mental health, parent issue, whatever it may be, right? This is all the kind of the bolt-on benefits that are built into your program, right?
Exactly. Our EAP is not. It's an EAP from a regulatory standpoint. It doesn't resemble any traditional EAP that probably most of us are used to seeing in the market. It's really designed to provide the access to care and the support to wrap around, a sharing program like Sedera.
Perfect. Well, Bill, Joe, we appreciate your time going through your solutions here. Folks on the phone, if you have any questions, feel free to reach out to myself, Laura Van Hootie, or your account manager. Again, we'll have a copy of this recording that we can push out as well. And then on my screen, I'm sharing our next webinar is scheduled for next Friday, 3 to 4 p.m. So tune in right before, I guess, happy hour and the weekend starts. This webinar really should be applicable to any self-funded employer, number one, any fully insured employer that's kind of been tiptoeing and thinking about moving to self-funded. Jennifer Johnson from Southern Scripts will present a pretty eye-opening presentation about all the different hidden costs built into most pharmacy benefit manager models and different ways that rebates might not be getting back into your pocket. So it should be a very interesting discussion, especially if it's applicable to your employer group. With that, I'll go ahead and close out this webinar. I appreciate everybody's time jumping on the call, and everybody have a great weekend.
Thanks, Matt. Thanks, everyone.
Take care.